Good evening, everyone. I am going to present on the topic of principles of observational studies. I am hoping that this is a more or less review for you, but let's go on to discuss the fact that science is, in general, a study of causality. So in a generic form, you're talking about cause resulting in an effect. In biomedical research, the term is exposure and disease. Nonetheless, same concept, cause and effect. An example in hepatology may be hepatitis B virus causing hepatocellular carcinoma. So I'm going to start with a study design question here. If you want to test the hypothesis that hepatitis B virus causes hepatocellular carcinoma, which of the following may be the strongest study design method? Number one, you find 100 patients in your practice with hepatitis B virus and see who has HCC. Number two, you identify a group of 1,000 people and test them for hepatitis B. You follow them for 10 years and see who develops HCC. Third, you find 100 patients with hepatitis B and 100 patients without hepatitis B in your practice and follow them for 10 years and see who develops HCC. Number four, you find 100 patients with HCC and 100 patients without HCC in your practice and test them for hepatitis B. And number five, you randomize subjects without hepatitis B and give them or inoculate 100 of them with hepatitis B and another 100 with placebo. Follow them for 10 years and see who develops HCC. I'll come back to this question. So the biggest branching point for study design is interventional versus observational studies. And as we just discussed, a causality example is hepatitis B causing HCC. An observational study design will include identifying people who have exposure to hepatitis B and identifying people with the disease HCC and dissect the correlation between the exposure and the disease through a period of follow-up. In this case, it may be decades. An interventional study, you actually intervene to control the exposure, and typically would be a randomized control trial where you give hepatitis B in a group of patients and placebo in another group of patients and see who develops HCC. That's obviously very questionable study design, but in concept, that would be an interventional study. So this is what I call causality matrix. There are two axes here. One is control of exposure. As we just discussed, trials have you control the exposure in subjects that may be linked to the disease. The other axis is how strong the study design is, or internal validity, therefore lack of biases. So along those axes, randomized controlled trial is strong. Cohort study on the observational side is strong. Non-randomized trial or case control study would be weaker in terms of internal validity. So if you look overall, the strengths of causality, randomized control trial would be the strongest, and perhaps case control study would be the lowest. So when you have these multiple study designs, how do you decide which study design to adopt? And it may depend on a number of things, such as how strong is the hypothesis. If the hypothesis is strong and you're confident that you will prove the case, then you may want to take on a study that may be more involved. Whereas if the hypothesis is not strong, then you would try to design a study that is more cost effective and hedge your bet against using a lot of resources for a negative study. How common is this disease to study, and how common is exposure? And depending on the instance or prevalence, instance of the disease and prevalence of the exposure, you may want to find a study design that zeroes in on those rare occurrences. And I'll go to individual study design to discuss this. And then practically, what resources are available for the study, and different study designs have different resource requirements, and that will be an important consideration. If feasible, in general, interventional studies or randomized control studies generate stronger evidence. Advantages of interventional studies: they are gold standard to determine cause-effect relationship, and it minimizes confounding by randomization. Disadvantages of interventional studies: it's potentially limited in terms of generalizability because you end up having very strict entry criteria for study subjects. Not always ethically possible, as we just discussed, for hepatitis B inoculation. Not always practically executable, and often unaffordable. So although there are strengths with interventional studies, not always possible. So today we're going to talk about observational studies, which include cohort study design and case control study design. Let's go to cohort study. This is the most intuitive observational study design, where a group of individuals with known initial exposure characteristics are followed prospectively and subsequent outcomes are measured. In the hepatitis B HCC example, you would take a population, identify all subjects with hepatitis B infection, and follow everyone with and without hepatitis B long enough to find all cases of HCC, and then compare the incidence of HCC between people with hepatitis B infection and without hepatitis B infection. So simple enough. Not to belabor on the point, graphically, at the beginning, you would identify a population and determine who has hepatitis B and who doesn't in that population. Over a period of time, you would follow those individuals. Eventually, patients will develop HCC and others would not. So you will have a population at the beginning, you know the prevalence of hepatitis B, and later on you would be able to calculate the instance of hepatocellular carcinoma. If you generalize this concept, you have a population, you have exposure and no exposure, disease and no disease, and we have 4 arrows going left to right, and you would have hepatitis B patients developing hepatocellular carcinoma. That would be A here, and there are patients without exposure who do not develop disease. That would be D here. Not all hep B positive patients will develop HCC. That's B. Some patients without hepatitis B will still develop HCC. That will be C. So this is the 2x2 table that will result from a cohort study. Once you have the data, how do you calculate, how do you analyze the data? As we just saw, you have 2x2 table based on exposure, no exposure, disease, and no disease. The total column here gives the prevalence of exposure versus no exposure, instance of disease among those with exposure and instance of disease among those without exposure. So the instance of disease among the exposed, let's say IE, is a cell divided by the total. So everybody with hepatitis B, some developing HCC, the instance will be number of HCC divided by all with hepatitis B. The instance of disease among the unexposed here is C divided by C plus D, same thing. Among those without hepatitis B exposure, some will develop HCC. So instance here will be C divided by C plus D. The bottom line metric for a cohort study will be the relative risk here, which is calculated by the ratio of these two instances. So IE divided by IU, or you can replace these with the individual formula for these instances here. That would be the bottom line. So beyond this abstract description, let's look at an example. This is a cohort study example that came out in New England Journal of Medicine. Dr. Yang in Taiwan conducted this study. It's a cohort of nearly 12,000 individuals from 7 different townships in Taiwan. It recruited in the early 1990s. And they followed these individuals until 2001 with the median follow-up of about 8 years. Now we have this 2x2 table: exposure, surface antigen positive, disease positive, 83. The total was 2,361. So the instance of HCC among surface antigen positive was 83 divided by 2,361. Same thing for instance among those without surface antigen will be 29 divided by 9,532. So if you do the math, the relative risk of surface antigen versus HCC, 11.7, the ratio of these two numbers. The interpretation of that number being hepatitis B virus infection is increases the risk of HCC by 11.7 or almost 12 times. Strong increase in the risk of HCC. Very important information, a very strong piece of evidence. So that's the cohort study design. The advantages of cohort study are it's the only way to directly establish instance, the absolute risk. It is strong evidence in causality, accurate exposure data because you're collecting the exposure at the beginning of your observation yourself. And then it allows study of the relationship between exposure and many diseases. If you think about some other possibilities where hepatitis B may cause another disease other than HCC, for example, cirrhosis, vasculitis, kidney disease, things like that, you can throw in those data collection and be able to study relationship with those different diseases with one study. Disadvantages: it is an inefficient way of studying things because you need a large cohort for rare diseases. HCC, after all, is relatively rare, so Dr. Yang had to go out and collect 12,000 individuals to follow for 8 years. So the follow-up of large number of patients gets expensive, and many years or decades may be needed between exposure and disease. So it's a lengthy study, and if you have a wrong hypothesis, you may end up spending your career of many years or even decades, end up with a negative study. The studies are limited to exposure data collected at the outset. So if you have hepatitis B exposure and you follow them forward, that determines hepatitis B as an exposure variable. But if you wanted to study hepatitis C, and Dr. Young in the 1990s did not have hepatitis C data, so you could not study that. So that's a disadvantage for a cohort study design. Let's turn to a case control study. This is the cohort study that we just discussed, and I'm showing this to you so we can contrast that against the next slide, which is a case control study. Here, you don't see a big population being followed forward. You just have 4 circles. And whereas the cohort study, you went from left side to the right side of the screen. Now, case control study, you go backwards. You start from the disease circles. People with HCC, people without HCC. Then you go back and determine who has hepatitis B and who does not have hepatitis B. So here, HCC are cases, no HCC are controls. Sometimes people get confused that hepatitis B is case and no hepatitis B is control. That is not the case. In a case control study, cases are those with disease and controls are those without disease. So once you have identified who has the disease or not, and then you track down who has exposure or not, okay? So once you have done that, then you have similar 2x2 table here. Patients with HCC who, when tested, test positive for hepatitis B, that's cell A. Patients without, individuals without hepatocellular carcinoma, you get tested for hepatitis B, and no hepatitis B, that's cell D. Patients with HCC without hepatitis B is C. Without HCC but having hepatitis B will be cell B. Very similar 2x2 table, totally different way of getting those data. So again, this is a generalized form of case control study. Cases, controls don't get mixed up, exposure and no exposure. Okay. So once you have the disease, the data analysis becomes a bit, is similar, but a little bit different. Here in the core study design, we used to have the total column, which is the total number of people with exposure. In case control study, if you think about it, we don't know what that number is. We don't know at the beginning how many people in the population had exposure. We just know the proportion of people with and without exposure. So A plus B or C plus D in this particular circumstance has no meaning. We cannot calculate the absolute instance in a case control study. Instead of the relative risk that we were able to calculate in the cohort study, in a case control study, we can calculate odds ratio. The odds ratio is simply A times B divided by C times B, AD over BC. The meaning of this ratio is similar to that of the relative risk, which is the strength of the case control study design. So let's look at an example. This is a Jorge Morelos study that was published some time ago as a case control study analyzing the relationship between HCC and alcohol use. 70 patients with HCC identified at a hospital clinic, those are the cases, and 70 matching controls without HCC at the same clinic. So those are the controls. Then they went back and collected alcohol use history by a questionnaire in the clinic. They were able to generate this 2x2 table. 48 individuals, HCC, had alcohol use out of 70. Out of 70 controls, 26 were heavy drinkers, 44 were not heavy drinkers. So odds ratio, this times that divided by this times that, here, ended up with 3.7. Interpretation of that number is heavy alcohol use is associated with about 4 times more odds to develop hepatocellular carcinoma. An important thing to think about is that if you do a case control study well, you get the right answer. So we shared this table with you from New England Journal paper. 11.7 was the relative risk in the cohort study. But what if he did a case control study, and you can imagine that he would pick 50 cases of HCC and 100 controls in this setting, and if the selection of the exposure, if the selection of cases and controls were proportionate with regard to the exposure, then you would get a result like this. So HCC 37 versus 13, this is the ratio, and then no HCC here, this is the ratio, 19 versus 81. If you do the odds ratio, this times divided by that times that, you get 11.9. See how close these two numbers are. Relative risk of 11.7 versus 11.9. So if you do the case control study correctly, you get the right answer. A key concept here is that everything needs to be proportional compared to the cohort study. Stated in a different way, in a generalizable way, a case control study will give the right answer only if selection of cases and controls are random with respect to exposure. So let's make a fake example here. Again, a case control study, the most important thing is how controls are selected. It needs to be random with regard to the exposure. So Jorge Marulo's study, let's say heavy alcohol use, cases were picked from liver clinic that has HCC, and you have something like this. And then controls, let's say they were confused, and they collected non-HCC cases in alcohol addiction clinic, where most people would have heavy alcohol use, but very few people would have HCC. So if you did this analysis, the odds ratio would be 0.1, which is interpreted as heavy alcohol use associated with lower risk, only 10% risk of HCC compared to those who are in the controls. So again, this is a problem because cases and controls are not comparable. The solution is you need to have thoughtful selection process for cases and controls and avoid biases in measurement of the exposure. So I'm coming back to the study design question. The first answer, this is a cross-sectional study. The second is a cohort study. Number 3 is, this is not a study. I hope you don't do something like this. Number 4 is case control study. Number 5 is a randomized control study, but ethically unacceptable. So strongest design may be randomized control study, but this study cannot be done. And so the best, second best might be a cohort study. So to summarize, research is a study of cause and effect relationship I share this matrix with you. And today we talked about interventional versus observational studies. Interventional studies are RCTs, higher validity. Cohort studies in the observational side is strongest of observational studies, but difficult to do. Case control studies are easier to do, but there is a potential to introduce biases, especially if you don't pick the controls in the correct fashion. Thank you very much for your attention.
Hello, it is my privilege to be with you today to discuss how to do database research. My name is Elliot Tapper and I am Associate Professor at the University of Michigan. I have some disclosures to make which are not pertinent to this discussion in any way, shape, or form. So let's get started. The first step when attempting to do database research is to develop your question. And sometimes when doing that, you can develop your question based on your knowledge of the potential and capabilities of the databases that you have available to you. And how this plays out will become clear in the slides and examples to come. So from my own personal experience, one of my favorite stories is about the time I discovered the publicly available for everybody and all nations data set from the Center for Disease Control and Prevention called CDC Wonder. This is a data set which tells you all about mortality in the United States, because every death certificate in the United States is collated and coded in this database. And I learned that my friend and collaborator, Dr. Sumit Esrani, had published a very interesting paper about rates of mortality due to liver disease using this data set. And it terminated in 2008. And looking at this in 2016, I saw an opportunity to extend this further. So step number 3 is to define the population. Once you know about the database and you have a question in mind, in this case, to define mortality due to chronic liver disease, you have to understand how those patients are identified in the database at hand. And typically, the way patients are identified is the use of administrative data codes. In the United States, through 2015, this was done using ICD-9 codes. Now, if you used one ICD-9 code, you could identify patients with, for example, varices, 456.0 up at the top, with a sensitivity of 2.5% and a specificity of 99.6%. And so this is instructive because it's very important to know that if you are describing the outcomes of people who have this condition, it is highly specific, but it cannot really tell you about the general population burden of this condition, because obviously it's missing many, many people that have this condition owing to its poor sensitivity. Now, you can improve the positive and negative predictive values by using 2 ICD-9 codes. So this is a process that, for the purpose of liver disease, was pioneered by Dr. Fasiya Kanwal. And so once you know that a patient has a code for cirrhosis, then if you add on the ascites code to that, the positive predictive value and negative predictive value increases substantially. So it is conventional to require your patients to have 2 diagnosis codes so that the whole world knows that you are dealing with people who have cirrhosis and a complication responsible from that cirrhosis. Now, that's only for ICD-9. And our data about the performance of ICD-10 codes is actually quite limited. And that is something that is worth thinking about for your own independent research projects. But if you are interested in a coding algorithm which has been designed and validated to identify the most people with cirrhosis, I provide it for you here in a paper that is led by Dr. Ian Rowe from the United Kingdom. This will help you identify patients with cirrhosis from a claims database. I'm also interested in using other streams of data to identify conditions of interest. And my condition of interest is hepatic encephalopathy. And so I looked at the performance of codes that are used for these conditions, which I lay out in this table. But I also look at the performance of the medications that are used to treat these conditions. And while we know that lactulose and rifaximin have other treatment targets, such as constipation or irritable bowel syndrome, by and large, once a patient has known cirrhosis, the use of these medications is quite sensitive and specific for the condition of interest. And so I advocate using medicines like lactulose to identify encephalopathy and spironolactone to identify ascites. So now you're doing your research, and you have to think about the kinds of trouble that your data will have as you go through the review process. So the first thing that a reviewer is going to pick apart is that it's very hard to positively identify fatty liver disease and alcohol-related liver disease. So the trick is to make sure that patients that have cirrhosis do not have other causes of liver disease. Although we all know that people with fatty liver disease can have overlapping conditions. For the purpose of database research, you need to exclude hepatitis C, hepatitis B, autoimmune hepatitis, and the like. And then for alcohol-related liver disease, now many people will put a non-specific cirrhosis code for those patients. But they might also have codes for alcohol use disorder or alcoholic neuropathy or cardiomyopathy. And by using those additional tests, you can begin to reclassify patients as having unspecified cirrhosis as alcohol-related liver disease. Now, people always want to know about the child class of your patients, and you simply cannot do that using ICD-9 and 10 codes, but you can add some depth by looking for procedure codes such as paracentesis and medications such as diuretics and lactulose and rifaximin. People love to know about cause of death, and I frankly don't know why. Once you have decompensated cirrhosis, your cause of death, no matter what it is, was somehow contributed to by that cirrhosis. And you simply have to say that this is a limitation of data. People want to know about duration of illness. Do you know if it was incident disease or how long they've been living with it? And if you happen to have a longitudinal data set and you say that these patients had 6 months of claims without a cirrhosis diagnosis, then effectively what you're doing is you're identifying people who have incident diagnoses, which I call washout. And these are some good strategies to consider moving forward. So step 4, to choose the outcomes of interest. Now, I want you to think very carefully when choosing these outcomes, because it turns out that if you're interested in mortality, that is a great outcome. But there is a unique competing risk for that mortality. And that competing risk is liver transplantation. And so if people are censored for liver transplantation, you're going to have incorrect estimates of association and effect for whatever modeling that you're doing. And similarly, if you're interested in the risk of decompensation, then death due to something like heart disease before decompensation is a critical competing risk. So understanding those competing risks is essential. And if you're interested in data methods for handling this, I recommend this reference, now 6-7 years old, from Dr. Peter Jepsen from Denmark. So a couple of analytic strategies to consider. So let's say that you have simultaneous timing of exposure and outcome. So your design here is effectively cross-sectional. So your outcome type is going to be either yes or no, the patient has the condition or not, or something continuous like cost of care or days spent in the hospital. And if it's a categorical outcome, you'll use logistic regression. If it's continuous, you can use linear, but if it's a skewed outcome where many people have 0 and some people have 1,000,000 of whatever the outcome may be, then it's important to use some kind of log transformed or negative binomial regression method. The outputs for these methods are detailed here, and the pitfalls really are missing data. Now, if the timing of the exposure and outcome are separated by time, either retrospectively or prospectively, you're going to be dealing with that competing risk and informative censoring problem. And here, what I would ask you to do is to consider whether or not you have a categorical outcome, which is probably the least sophisticated approach, where you would use logistic regression using an odds ratio. I would prefer that you use time to event with a hazard ratio, but if you're interested in the risk of an event or events over time, you'll use incident rate for events over time, or the risk of an event as an incident rate ratio, and addressing competing risks is essential. So back to my story. We're now interested in analyzing our data and presenting it in a way that's going to be published. So I was aware that there was this great database about mortality for patients with cirrhosis. And I looked around to try to see how people represented this kind of data. I was interested in showing differences in the trends in mortality due to cirrhosis over time. And as I was doing this, I encountered a paper written by Dr. Fasia Kanwal and Dr. El Sarrag, whose papers I always look up to. And here they wanted to do the incidence of liver cancer over time and the trends therein. And the way that they did this was by showing the average percentage change in the incidence of their outcome of interest, and they analyzed it using a method called join point. Now, I've never heard of these things at this time, but I then looked into the method, found out that it was a free software I could download. I taught myself how to use it, and I used this table as a model for how I would then present my own data. So you look at their table, and then you see mine. When I eventually presented it, I showed the various different subgroups of people with cirrhosis and the different time frames and the annual percentage change in mortality for each of those subgroups, just like my mentors from a distance did for their incidence paper. Now, they pictorially described the geographic distribution of mortality in a given year using these maps, and that looked pretty good. So I took these maps of incidence and I inverted it to maps of mortality presented year on year in the United States. And what the result was a story where not only could I do that kind of fancy analysis using joint point, but I could describe that mortality had been rising over time since the time that Dr. Israni concluded his study in 2008, and the result was a paper that made a nice splash. Now, I subsequently took that approach and extended it into a review article that you can see here, which is open access at this point. And in this review article, we talk about the strengths and weaknesses of various databases. Now, some of these databases are not available to people without special licensing, like the Veterans Affairs or the Medicaid database. But anybody in any country can buy and can get NHANES data for free, or can buy National Inpatient Sample or National Readmissions Database data for a fee. And these are potential sources of future database studies. So I want to tell you about a real-time example so you can see how I begin applying these methods prospectively. So I was very interested in looking at the sources of frailty. So I'm very interested in the cognitive impact on the liver frailty index developed by Dr. Jennifer Lai. And I became aware of a data set available to me for free through the NIH called the Framingham Heart Study. And the Framingham Heart Study is looking at things like cardiovascular outcomes, but they're also assessing frailty, from which you can derive a liver frailty index. And you can assess people for the presence of liver disease using things like FIB4 and FAT on CAT scans. So I built a team. Michelle Long is a hepatologist at Boston University who is the world's authority on liver disease in the Framingham Heart Study. That's good to have. Neil Parikh is a neurologist with expertise of cognitive function in patients with liver disease. And then I had my worker bees, Manav Mehta and Jeremy Louis Saint, who would do all of the analysis. Then I write the introduction, which helps me understand the literature and the building up to this study and the gaps in that literature, so I know what particular ways to refine my research question would look like. Then I learn from reading as I'm pulling papers, trying to understand the background for my introduction. So for example, I learned that a group from Israel had evaluated the association between fibrosis indices and fatty liver disease with cognitive function in the Framingham study. So this immediately told me what I shouldn't be analyzing because it's already been done, but it also clued me into how to analyze the data, how to code and clean the variables. And then, once I knew what I was planning on doing, I created shell tables. So I said to my worker bees, I want to do linear regressions for performance of each of the metrics that are bound up in the liver frailty index. I was interested in fibrosis indices, but also alcohol use from surveys, BMI, cystatin C, because cystatin C and creatinine are indirect measures of sarcopenia, inflammatory biomarkers, and neurocognitive function. And this, although it wasn't the final result in the paper, told me what I needed my worker bees to code in the database and what kind of methods we needed to find these particular databases. The result for us was a publication about a year later in a nice journal. So the last thing I'm going to leave you with is that we didn't talk about how the worker bees, that I called them, actually did the work. And many people are looking for software to help them analyze large data sets. And you'll hear about SPSS, you'll hear about SAS and Stata, and each of these are good in their own way. But one program is free. One program is customizable, and that program, its name is R. And if I were in your shoes and thinking about a career in database research that would take me decades into the future, I would spend the time to learn R. There are many videos and free courses online through YouTube or Stanford that can help you understand how to get on your feet using R, and I strongly recommend that you take a look at those. Keys to success here are to read. The more literature you read, the more you're going to be aware of the databases, data sources, and analytic strategies available to you. Then you plan things out. You make sure you know how to identify your population of interest. You make sure you know about the gaps in the literature and align your analytic plan accordingly. And you define your population and outcomes carefully to make sure that it will stand the test of peer review. Thank you for your attention.
Good afternoon. My name is Sid Singh, and I'm happy to be talking to you about how to conduct a systematic review in meta-analysis. I'll focus on the top 10 common pitfalls and how to avoid them. I'm a gastroenterologist at University of California, San Diego. I have expertise and interest in knowledge synthesis and evidence generation. I am the incoming chair-elect of the AGA Clinical Guidelines Committee, where evidence synthesis is paramount. And I also am the associate editor for clinical gastroenterology and hepatology, where I handle systematic reviews and meta-analysis. In this talk, I will focus on what a systematic review and meta-analysis is, how do we conduct these, and what are the main pitfalls. Let's start off with talking about what a systematic review is. A systematic review involves comprehensive and systematic search for evidence of published and ideally unpublished literature to answer a very focused, narrow question. This is protocol-driven and inherently reproducible with explicit inclusion and exclusion criteria. It utilizes multiple measures to reduce bias, again in a bid to make sure this is reproducible. It critically appraises and summarizes the available evidence to answer the specific focus question. A systematic review may or may not involve a quantitative synthesis. Meta-analysis is a quantitative summary, ideally of a systematic review. The benefits of a meta-analysis is that it often offers greater precision. It increases the power by increasing sample size and the number of events by combining multiple studies, and it yields a single summary estimate. It is very significant for rare events such as harm and secondary outcomes of clinical trials where the individual trial may not be powered for those rare events. A meta-analysis allows for a more generalizable summary estimate with wider inclusion criteria, and it may help to identify subgroups where specific treatments may be more or less effective, something that individual studies may not be able to pick up or be adequately powered for. Let's talk briefly about how to conduct a systematic review and meta-analysis. In this slide, I will list out all the steps involved, and subsequently we'll go into details of each individual step. The first step is to develop a focused and a clinically relevant question. This is probably the most important and surprisingly the hardest thing to address. Subsequently, around this focused, clinically relevant question, we need to develop a protocol which will be followed by multiple investigators or the investigator team conducting the systematic review. Subsequently, we need to design and conduct a literature search, ideally in conjunction with a librarian. Subsequently, we select articles of interest that meet our inclusion and exclusion criteria. We abstract data, relevant data based on our protocol which is predefined. We appraise the individual studies or assess the risk of bias in these individual studies. And subsequently, if we anticipate performing a quantitative synthesis or meta-analysis, we conduct this analysis. Finally, we infer the findings and assess its implications for clinical practice, and use this to identify gaps in the existing literature and provide recommendations for future studies. Sometimes people feel that a systematic review is the last thing that needs to be conducted. I would argue that systematic reviews play an equally important role in identifying gaps in the existing literature besides bringing up and critically appraising the evidence to date. The top 10 most common pitfalls that we see in systematic reviews and meta-analysis, and things that I would look out for when I'm reviewing systematic reviews, is focusing on the choice of focused question and oftentimes lacking an a priori defined protocol. Frequently, we see that the research is very narrow, missing trial registries and excluding conference proceedings or excluding non-English language articles. Sometimes we see no independent and duplicate study identification and data abstraction, and oftentimes there is inadequate assessment of risk of bias in individual studies. Sometimes there may be inappropriate use and approach to quantitative synthesis. Specifically, if the studies are conceptually heterogeneous, then it is difficult to quantitatively summarize and come up with a single summary estimate. Perhaps the thing that we see most commonly is overinterpretation of the results of subgroup analyses. More recently, there has been an emphasis on critically appraising the entire body of evidence or the quality of evidence using various approaches such as grade. It is important to complete a systematic review with translating these findings into implications for clinical practice, such that an individual day-to-day clinician can use these findings to apply. There are some alternative quantitative synthesis approaches that should be considered if relevant to the question, such as network meta-analysis, and I'll talk about all of these points in greater detail in the course of the talk. Let's start off with a focus question. The focus question needs to be clinically relevant with enough ambiguity in the existing literature. If all the studies point in the same direction, then the novelty or the relevance of that question goes down. These focus questions can rely on incidence or prevalence studies, which would ideally be based off of population-based studies. There may be systematic reviews of associations and risk factors. The important thing in these studies is that these risk factors should be consistently reported both in positive and negative studies. Frequently, we see that a positive risk factor is frequently reported, whereas studies in which the same risk factor was not found to be significant may not adequately adjust for covariates and present the relative risk or odds ratio. There can be systematic reviews of focusing on diagnostic accuracy. It is important to keep in mind that in these studies there is an adequate gold standard and accounts for spectrum bias. Treatment efficacy systematic reviews frequently rely on randomized clinical trials. Harm assessment and adverse events can rely on both randomized trials as well as real-world evidence from observational cohort studies. Finally, the focus question may rely on a question of prognostic utility. Here again, similar to risk factors, consistent reporting and adequate adjustment for covariates is critically important. The next step is defining a protocol before conducting the study. It is best, once you have identified your clinically focused question, to break it down into a PICO format, where P stands for patients, I for intervention or exposure in case of observational studies, C for comparator or control, O for outcomes, clearly defining what the primary outcome of the systematic review is and what are the secondary outcomes that are of interest, and outlining the time period over which the studies or evidence will be identified. Clearly outline in this protocol what the inclusion and exclusion criteria are, including the type of study, which varies depending on the nature of the question. Again, it is important to recognize that protocols are very important because team members will be following that protocol and that is a source of reducing bias. You should have an analysis plan outlined ahead of time, including what subgroup analysis you are planning to do and what do you expect to be the findings in these subgroup analysis. This is important as we talk about interpreting or over-interpretation of subgroup analysis. And think about potential sensitivity analysis that you will be conducting. And remember that a protocol can be flexible and it can be modified depending on findings of the literature search. However, it is important to be transparent in this process, i.e. have an a priori defined protocol and then explicitly state at the time of conducting the systematic review how the protocol was adjusted. It is critically important to have a comprehensive search strategy. This search strategy should ideally be sensitive and not very specific. The different limits or concepts that can be applied, such as the type of studies like clinical trials, epidemiological studies, incidence or prevalence studies, and similarly define synonyms and terms that are being used. Frequently involves combining mesh terms as well as text words, and always needs to be searching multiple different databases, including conference proceeding and now more recently preprint servers. This has become increasingly common with the recent COVID-19 pandemic, where a lot of studies are frequently published in preprint servers before undergoing peer review. Make sure you hand search references of selected articles. This a specific reference provides a systematic approach to conducting a literature search. I have relied on a librarian to conduct these systematic reviews because these literature searches are very expensive. The next steps are minimizing bias in the process of study selection and data abstraction. So while your original search can be conducted and should ideally be conducted by a librarian with input from study investigators, subsequent steps of study selection as well as data abstraction require two independent abstractors. Two abstractors who know the protocol very well and can apply those criteria independently. This should be performed in duplication, in pairs, and ideally you should be performing a kappa coefficient for agreement for study selection at each step, including full text screening based on title and abstracts as well as full text screening. Similarly, once you have identified the studies for inclusion, all data abstraction based off of your protocol or based on factors that you think are most important should be conducted in duplication, again independently. At the very minimum, for important variables such as exposures and outcomes, or interventions, comparators, and outcomes, which will go into the analysis of the systematic review, that part should be conducted in duplication for sure. There are multiple tools available which can be used to track this concept of duplicate article selection, such as Abstractor, EpiReviewer, Covariance, Distiller, and Ryan is a free software that is available that can help you with article selection and duplication, and also calculate your kappa coefficient. The next step in a systematic review is risk of bias assessment. This implies a critical appraisal of each included study and allows us to estimate the overall risk of bias in the existing evidence and literature. There may be different tools that are used for appraising the risk of bias depending on the study design. For example, for randomized clinical trials, there's the Cochrane Risk of Bias Tool version 2. Depending on the nature of your studies, including case control studies, cohort studies, incidence and prevalence studies, as well as cross-sectional studies, there are multiple different tools designed specifically for the study available from the Joanna Briggs Institute. Sometimes I've had to modify these existing tools to suit the nature of my question and the focus question that I'm trying to answer. And the key thing is trying to do your best to appraise the risk of bias in the available evidence. Remember, this risk of bias is a qualitative assessment, although I frequently see this being performed as a quantitative cutoffs for different tools. Ideally, you should identify which are the factors that play the biggest role when interpreting this evidence and use that as a qualitative tool and subsequently for sensitivity analysis. The next biggest question is analysis, whether to pool or not to pool. Are these studies apples and oranges that should not be pooled, or do we think they're close enough that it would make sense to pool and combine these estimates? The assumptions in a meta-analysis are that all studies examine very similar patients, interventions, and outcomes. In my approach, I assert conceptual heterogeneity in conducting a systematic review. Is there enough clinical heterogeneity, i.e. differences in patient populations, or enough methodological heterogeneity with differences in study design, exposure, and the way outcome was assessed? That helps me understand whether or not it would make sense to conduct a quantitative synthesis or not. If the studies are conceptually similar to each other, I frequently will rely on a quantitative synthesis, although I would be cautious in interpreting the results if there's high heterogeneity statistically that is observed. Again, like I said, if this is biologically plausible and there's a similar approach in these studies to answering the question, it may be okay to combine and perform a quantitative synthesis, or at least when thinking about developing the protocol. How do we combine these different studies? The best approach is to use a weighted mean if all of the trials are very similar to each other. The weight is based on precision, and variance is a lack of precision, and hence an inverse variance represents the best weight. This is fundamentally the concept of a fixed effects model. Now, you would have likely seen two different models for analysis, including fixed effects and random effects model, and there are aspects related to heterogeneity. I will talk about these in a little bit more detail. However, to help with the analysis, there are different tools which are available, including RevMan, and I will do a walkthrough through RevMan for a systematic review and meta-analysis. There are other tools which are available for purchase, including comprehensive meta-analysis, as well as packages within R and other standard programming languages. The choice of method for most analysis is invariably a random effects model. This is a priori based on anticipated clinical heterogeneity, which is a random effects mostly seen except for some rare exceptions. For example, if multiple studies have been conducted using an identical protocol by the same drug manufacturer. A data-driven approach to choosing the model is not appropriate. Frequently, we see that investigators report conducting a fixed effects model just because they felt there was not enough statistical heterogeneity at the end of the analysis. You may be able to revisit this decision post hoc based on your results. For example, if you are a priori decided to proceed with a fixed effect model, but you recognize that there's a high statistical heterogeneity, then perhaps a fixed effect model is not appropriate. Similarly, if you identify that there are less than 5 studies, and these studies are conceptually very similar to each other, then maybe using a random effects model may not be the best thing, because it can be unstable between study variance estimate, and in these instances a fixed effect model may be more appropriate. What you need to know is that in the absence of any statistical heterogeneity, the finding from a random effects model and a fixed effects model is identical. Let me walk you through RevMan. RevMan is one of the most commonly available tools through the Cochrane database, and it is used for multiple different kinds of meta-analysis. It is freely available for use and can be used for multiple different kinds of studies. The example that I walk you through is an interventional systematic review and meta-analysis for 2 different treatments. First off, when you open RevMan, you'll identify and define the type of review, because that'll define the type of data that you would need to enter. Choose an intervention review and subsequently add your identified studies within this. Once you have inputted all the studies that will be used, move to the data and analysis section and add comparisons. Here, as you open the outcome wizard, it'll ask you what kind of data you're using or applying. For most clinical trials, this is dichotomous data where you're entering the number of participants with events and the total number of participants in both the experimental and control groups. Finally, you will choose the statistical method. Here you can choose a random effects model, and for statistical methods with a reasonable sample size, the Mantel-Haenszel approach is probably the best. You can choose different kind of effect measures, how you want to report your results, including odds ratio, risk ratio, or a risk difference. And once you have chosen your approach, you can subsequently add study data for each outcome. What this will look like, for example, as you add each individual study, comparing 2 different outcomes, you'll be able to input the number of events and the total number of patients in the experimental as well as control arm, and it will automatically generate your forest plot, which is the best way to represent the findings of a meta-analysis. As you go deeper into the software, you'll be able to as you go through the software, you'll be easily able to understand other different things, including subgroup analysis, which is a way to address heterogeneity. Heterogeneity is any variability among the studies in a systematic review. There may be clinical heterogeneity due to variability in the patient's intervention, control, and outcomes, including differences in the age, sex, ethnicity, maybe studying different drugs within the same class, definitions of exposure and outcome in the nature of the study, or there may be methodological heterogeneity such as variability in design and risk of bias. This may be based on study quality and design, the method of exposure and outcome assessment. And finally, there is statistical heterogeneity, which is variability in the observed effect. You can quantify and should quantify heterogeneity. There can be 2 different approaches, including the Cochrane's Q test. The null hypothesis in the Cochrane's Q test is that all studies have the same effect size. A significant p-value rejects this hypothesis and suggests the presence of significant heterogeneity. Perhaps a better way to quantify heterogeneity, however, is the I-squared index or the inconsistency index. This denotes the percentage of total variation across studies that is not due to chance. Frequently, we use a cutoff of more than 50% to suggest statistically significant heterogeneity. However, like I said, methodological and conceptual heterogeneity is equally important, rather than relying on a single number which may suggest statistical heterogeneity. One of the things that should always be performed in conjunction with a systematic review and meta-analysis are subgroup analysis. Subgroup analyses are an attempt to explain heterogeneity to assess whether or not there may be differences in findings in specific predefined groups of patients. This should not just be limited to performing a subgroup analysis in the presence of heterogeneity, However, performing a subgroup analysis, even in the absence of heterogeneity, is important to confirm that the findings were consistent across different subgroups, across different nature of patients, and so on and so forth. One of the things, unfortunately, that we see frequently is we rely a little too much on findings of a subgroup analysis. I would suggest that we follow these criteria to ascertain whether subgroup analysis results are believable. First, these need to be defined a priori, and ideally you should define the direction of subgroup analysis a priori. For example, if you're trying to assess whether or not a specific medication is more effective in males and females, you should have an a priori hypothesis where you think a medication is likely to be more effective in men than in women, and denote that direction in your protocol. The results of the subgroup analysis should be biologically plausible, and ideally you want to see a large statistically significant difference. This difference should not just be seen in the overall summary estimate, but similar findings should be seen among the individual studies. They may not be reaching statistical significance in the individual studies, but as long as the point estimates are kind of on the same side of the forest plot, this would suggest consistency among the studies. This effect should be observed both within studies and not only between studies. And finally, for different kinds of outcomes, there should be an interaction that is consistent across these closely related outcomes. What is important to understand is that when you're performing subgroup analysis, don't just rely on the individual p-value or the 95% confidence interval and state that even though the point estimate for the two subgroups may be similar, if one of them crosses the 95% confidence interval and a p-value is not significant, it is incorrect to assume that there is a significant difference in the subgroups and the medication is only effective in one patient population and not the other. Finally, we'll talk about the concept of quality of evidence. Again, we recognize that each study and each systematic review has certain methodological limitations based on risk of bias, incomplete reporting, losses to follow-up, allocation concealment, and failure of blinding. These are just methodological limitations within individual studies. However, once you've summarized all of this evidence, you may still find that there's inconsistency in the results of findings from multiple different studies. You may be relying or focusing on one specific outcome, but trying to infer on a different outcome such that there may be indirectness of evidence, or you may be pulling data from pediatric studies and trying to apply it to adults. The results may be imprecise, wherein the confidence intervals seem to be crossing unity even though the point estimate may favor one medication over another. And finally, there may be publication bias. All of these concepts need to be incorporated when considering the totality of evidence and ascertaining the quality of this evidence. Again, the concepts of risk of bias apply to individual studies, but on top of it, aspects related to inconsistency of findings between different studies, indirectness of this available evidence, imprecision, and publication bias apply to the full body of evidence. Next step is to identify implications for clinical practice. It is important to make meaningful conclusions based on the summary of evidence, keeping in mind the quality of evidence. It is helpful to estimate number needed to treat or harm, especially if the results are homogeneous. This allows for clinical applicability. Ideally, this should be followed or have implications for clinical guideline development. And again, like I mentioned earlier, one of the key steps in a systematic review is to identify knowledge gaps and areas for future research. Let's briefly talk about some alternative synthesis approaches, specifically something called a network meta-analysis. Now, we know that a traditional pairwise meta-analysis is meant to compare two different medications that are being compared head-to-head. For example, if drug 1 has been compared to drug 2 has been compared to drug 3, and drug 1 has been compared to drug 4, you can perform 3 different meta-analyses to compare these different medications with the other one against which they've been directly compared. However, the concept of a network meta-analysis allows you to combine this direct evidence from head-to-head trials with indirect evidence based on a common comparator and allows you to generate a mixed effect estimate. Such an approach allows you to synthesize a probabilistic relationship between all the different medications used to treat different diseases and infer on the relative efficacy of these. For example, in this specific diagram, we know that drug 1 has not directly been compared to drug 3. However, both of these medications have been compared against drug 2, potentially placebo, and such that by looking at the relationship between drug 1 versus drug 2, and similarly between drug 3 versus drug 2, we can infer on the relative efficacy of drug 1 versus drug 3. With that, I will stop. I will be happy to answer any questions. Thank you again for your time and participation.
I would like to thank the conference organizers for the opportunity to present this session to you on how to read a basic science paper. So reading a paper is an exercise in critical thinking, the art of reviewing and questioning. And I'd like to articulate a number of key steps to follow that I think will make this process an easier one for you. First, an overview. Get the big picture or the 40,000-foot view. Then delve into and pay attention to the details of the publication. You need to bring an inquiring mindset with you. And that means questioning what you see and not believing everything you read. Then you need to be thinking as you're reading, how do I make a positive contribution to this work? Having that view will allow you to be inquisitive, ask questions, and actually learn the most from the exercise of reading the manuscript. So 40,000-foot view up here from an airplane window allows you to see the expanse of the sea and the individual clouds as well. If you were in the midst of one of these clouds, you would see nothing. It would be just white out. So it's good to get above the clouds. You can then see the horizon. So how do you get the 40,000-foot view of a paper? First things first, what is the main aim of the study? What is the problem the researcher is trying to solve? What is the specific hypothesis that is being tested? Is this work important, for example, to me and my work? The title, the abstract, and often the last paragraph of the introduction will give you the answers to these key questions. So it's helpful to review these in the first few minutes. These provide the overall context then for understanding the paper. Here's an example of a publication that we are reading. It starts out with a title that is actually quite descriptive. Sulfatase 2, brackets SOLF2, monoclonal antibody 5G5, suppresses human cholangiocarcinoma xenograft growth through regulation of the SOLF2 platelet-derived growth factor receptor beta, yes-associated protein signaling axis. So this tells us quite a bit about the objectives of the paper just in the title. Then we go to the abstract, which is a structured abstract that begins with a background in aims. Existing therapeutic approaches to treat cholangiocarcinoma have limited effectiveness, prompting further study to develop therapies for CCA, or cholangiocarcinoma. The authors say here we report a mechanistic role for the heparin sulfate editing enzyme sulfatase 2, or in brackets SOLF2, in cholangiocarcinoma pathogenesis. So they've told us 40,000-foot view, broad strokes. We're trying to improve treatments for cholangiocarcinoma, and we are doing this by studying the mechanism of an enzyme that edits heparin sulfate in cholangiocarcinoma pathogenesis. Then we go to the end of the introduction, and we see there more detail. The role of SOLF1, that's sulfatase 1, and SOLF2, sulfatase 2, in cholangiocarcinoma is as yet unexplored, as is the potential for translation to therapy against cholangiocarcinoma. So far, no agent targeting sulfatases is available in the clinic, And to address this gap, we performed this study in order to answer the following questions. Then they list specifically 6 questions about their study. So taking the title, the abstract, and the end of the introduction actually gives us a great capsule of why this study is being done, what it is that the authors are intending to do, and actually we also see even from the title what some of their results are. So now that we have an overall view of what they're trying to achieve here, now we can look at the details. And the next question in our minds is, how about the study design and methods? Is the design appropriate to answer the research question, or will the design allow acceptance or rejection of the hypothesis that's stated by the authors? And so now we want to evaluate the study design and methods. Do the experiments test the proposed hypothesis? Do the researchers use the right experimental methods? Do the researchers use the right controls? This is critical. Many experiments fail not because of in a sense, the intervention or the key observation that is being made, but rather because the appropriate controls that will ensure the validity of the results are left out. So key question, are the researchers using the right controls? Next, is the statistical analysis plan sound? Are there sufficient subjects in the study? Are there sufficient events that are under study as observations? This is particularly important with studies that involve some element of data from humans, because it's not uncommon for researchers to think of humans as mice. Mice, when you get them, are the same strain. There are no genetic differences between 2 or 3 mice of the same strain. So that allows us to do studies on mice where we use relatively few mice to try to answer a scientific question. Humans, of course, are much more diverse and heterogeneous. So in order to do studies on humans, we typically have to use more humans so that we can account for the variability between humans. So it's important to ask these questions, particularly if there's humans involved that are reported in the study. Is the study designed with sufficient power to tell differences? And again, just a reminder, don't believe everything you read or hear for that matter. Think critically about the information that's being presented to you. So next, it's important to examine for rigor and reproducibility. Is this science done in a rigorous manner? Is it likely that if we were to repeat those experiments in another laboratory or another setting, we would be able to reproduce this data in an identical or near identical fashion? So this picture here is of the Colosseum in Rome. And on one tour that I took of the Colosseum, the guide said, look at this view in front of us. What's the difference you see? And we said, well, it seems as though the left half of the Colosseum managed to survive much better than the right half of the Colosseum. And he said, well, the story is that when the emperor asked one of his courtsmen to put out the contract for building the Colosseum, the courtman went to look for the best builder in Rome and gave him the contract for the left side of the Colosseum. And then he went to his best friend and they gave him the contract for the right side of the Colosseum. And you can see that the work of the best builder survived much better than the work of his best friend. Now, I understand in truth that that's not the case. It just happens to be that this area sits close to a fault line and there have been a number of earthquakes, and the area to the right was just not as strong or stable, and so we saw more damage on the right side of the Colosseum. But it makes for a great story, because making the point, if you do your work in a rigorous manner, if science is done in a rigorous and reproducible manner, the work will hold up over many years. If it's not done in as rigorous a manner, it will not hold up as well. So how do we look for evidence of rigor and reproducibility? Often it's by looking to see if the work has been done in a way that it can be validated or replicated. So if the authors are using data on humans, for example, do they use more than one data set? Do they use, if they're doing genomic characterization, for example, of RNA sequencing data, do they use more than one data set and then compare the results to confirm that they are similar? If they're doing work with cell lines, do they use more than one cell line? Or they use only one cell line to make their whole case? If they use only one cell line, given differences between cell lines, how do we know that a different cell line will behave essentially the same way? Next, if the authors are looking at a gene or protein of interest, for example, do they examine the effects of gain, of expression, or of function of the protein of interest, as well as loss of function, to see if those effects are different or opposing, or they only look in one direction? If they do in vitro experiments, do they confirm the results of the in vitro experiments in vivo as well? So these are different ways that we expect science to be done in order that we see evidence that it's done rigorously and is reproducible. It's often the case that when we measure protein levels, for example, we'll make a lysate of a tissue and we'll do what we call a Western blot, an immunoblot of the tissue. When we do this, do you see in this experiment, the experiments, that these Western blots are confirmed also by a different method? For example, by immunofluorescence or biochemical or molecular assays, to show that the protein indeed with its increased expression, that we are seeing increased function of the protein. Are there sufficient replicates of each experiment? Is the experiment only done once or a couple of times, or is it done 6 times or 9 times to give us confidence that the same result is seen? And finally, do the results fit in an overarching model? Can we take the results of for example, different pathways, tie them together and show, using different checks, that indeed protein A causes changes in protein B, which in turn causes changes in protein C that are reproducible? So next, we want to look at the way in which the authors interpreted the results of the experiments. And this is found in the discussion section of the paper. And the key question here is, are the conclusions justified by the data? If data has been shown, are the researchers making a reasonable step from data that they've shown us to a conclusion, or are they overstepping the conclusion? Are they claiming more than they have shown us from the data that they've been able to develop? Next, will the conclusion have a substantive impact on the field? And this really goes more to the issue of what's really the impact or the importance of this publication. And it requires, and this is what you'll often see in a publication, in a discussion, is that the authors will set the context. They'll say, this is what is known so far about this field or about this area of science or research. And they'll say, we did these specific experiments in order to test this next step or this next hypothesis that we developed based on what is already known. And these are the results that we have. And then really it's up to you as the reader to judge, are these results important enough that they are likely to make a substantial impact or likely to lead to further experiments that might have clinical or translational significance? Next, it's important to ask the question, do the results suggest a new question or direction of research? Now, many authors will actually at least begin this process for you, because much of the time in the discussion, authors will write what the limitations are of the work that they've done. They'll say, we have these specific limitations on our work, And then they may also articulate what they think the major strengths are of their work. But often they'll end with what the next steps are. What's the unanswered question that remains to be seen as next steps from their work? And it's important to examine the publication to see if this is done. As you are examining and thinking about it, you may come up with a new idea that might lead you, if this is an area of your interest, into perhaps experiments or additional work to try to confirm the work that they've done and possibly to extend it. One of the ways that authors will usually report their work is to try to summarize it at the end with a summary cartoon. And actually many journals now will request that authors provide what they call a visual abstract. So this is a cartoon that in some way tries to highlight the results of the publication. So in the case of publication that we saw earlier, we see that the authors say we had this 5G5 antibody that is an antibody against this enzyme sulfatase 2. This is involved in targeting the platelet-derived growth factor receptor beta protein, its signaling through yes-associated protein or YAP, and the fact that this leads to growth of cholangiocarcinoma cells. And so in the course of their publication, what they've tried to do is prove different steps along the way of this study, so that at the end, when they show you this figure or cartoon, it helps to summarize or encapsulate the key elements of the publication. So another step that's important as you review this publication or a manuscript is to ask the question, were the appropriate ethical approvals obtained? Is there evidence that this manuscript, this research was done in an ethical manner? And typically at all institutions for human studies, there's an institutional review board or IRB or an ethical committee that provides approval for the human subjects aspects of a study. And there's often also, if there's animal studies, an institutional animal care and use committee or IACUC or other animal care committee that provides animal care approval. So you can see in this particular paper, they say the study protocol conformed to the ethical guidelines of the 1975 Declaration of Helsinki as reflected in a priori approval by the Mayo Clinic Institutional Review Board. So the human aspects were approved by an IRB. For the xenograft model that's done in mice, they tell us the care and use of mice for experimental purposes were carried out in accordance with the requirements set out by the Mayo Clinic Institutional Animal Care and Use Committee. So they show us the ethical approvals for their study as, again, proof of the rigor that was used in the study. The next thing is that it's important for authors to address conflicts of interest. Authors are required to declare if they've been paid in any way by any company or party that has an interest in the outcome of the research. And here we see the funding support for the study, different sources of funding as proof of the source of funding for the study and proof that there is no conflict there. Now, there may be potential conflicts, and here also we can see that there's a statement about advice and grants received from different commercial company consultation, advisory boards, and this helps to clarify for readers in case there might be some commercial benefits from this publication, that there's nothing that the author is not disclosing about the potential commercial gain from this. So it's important as we think about publications to think about how we might make a positive contribution to the work. Sometimes you'll read a publication and you'll think, it seems as though the authors did not consider this aspect or that other aspect that might be important in the interpretation of their work. And that is why journals give us the opportunity to write letters. Because you might see something and say, boy, having additional explanation or having examination of this other path of interest might be really helpful in building the knowledge of science, what I tend to call the wall of science. We are all scientists together building the wall of science, and we build it one brick at a time. And so maybe as you're reading someone else's paper, a thought comes to you about something that would contribute to that line of work. And if it's important enough, you might decide, I'll write a letter to the editor and make a point about this with the goal of making a positive contribution to the science that's being done. And so I liken it to bringing your best self to this manuscript that you're reading. As I said, we are all building the wall of science. Your perspective might be transformative. So look for opportunities as you're reading to contribute. At the same time, don't be overcritical of the authors. We all know how challenging it is to do some of this work, and it's important that we recognize the limitations of methods. We recognize that people sometimes don't have all the resources that they might need or that might be helpful. And so it's important to recognize that sometimes there are limitations that authors face in developing their work. It's important as you are trying to understand work that's being published, that if you don't understand particular aspects of the paper, you feel comfortable finding someone that's an expert in that area of the science and asking them for help. It is quite routine now that modern science is a team effort. People with expertise in many different disciplines will band together as a team to do the work of science and to publish a paper. And so in the same way, any individual reader may not have complete mastery of all the different aspects that go into a publication. And it's really helpful to ask for help. And I, for example, am much more of a biologist than I am of an analytical scientist. So if I am reading a publication and I see aspects that involve, for example, bioinformatics or artificial intelligence or machine learning models, I will often send the publication to a colleague and say, can you please explain this aspect or that aspect to me? And that really helps increase my learning and understanding of a publication. And finally, ask questions. As you're reading, think, what are the important questions that need to be asked of this publication? And plan to ask for any one publication. And I tell my fellows and residents, or anytime they listen to a talk, plan to ask at least one substantive question. What this does is it helps you focus as you're reading or as you're listening, and it maximizes your learning as well. So in summary, approach a manuscript review in stages. Get the big picture or the 40,000-foot view. That helps you understand the key objectives. Pay attention to the details of methods and analysis. This will really help you to establish whether the appropriate methods are being used as well as the appropriate analyses, and will help you to really get a sense of whether this work was done with rigor and might be likely reproducible. Bring an inquiring mindset, bring a questioning mindset. This will help you to determine whether there are major flaws in the publication. Think about how you would make a positive contribution, what you could do, or what ways this work might be improved. And finally, ask questions, because these really maximize your learning as you review manuscripts. Thanks very much for listening. And again, I'd like to thank the organizers for the opportunity to present. Thank you.
Hello, and thank you for this opportunity to share some of my thoughts on what it takes to publish in high-impact journals. My name is Elizabeth Verna, and I'm from Columbia University in New York. Here are my disclosures, including some research support, But I also wanted to disclose that much of what I know about publishing is actually from some of my AASLD activities, including being chair of the Practice Guidelines Committee, as well as an associate and then deputy editor of the AASLD journal Liver Transplantation. So you'll see that some of my examples in this talk come from this insider experience. So I'll start with a sometimes overlooked question, which is, why should any of us be interested in publishing? Certainly there are many people in the medical field who rarely do or don't really even aspire to publish, but I think there are a lot of reasons to publish the work that we're doing, including it's a great way to learn and to advance your career, to help prepare for promotion, be competitive for grantsmanship, and papers are certainly a central commodity in academic medicine. Publishing high-impact papers help not only you, but also the program gain visibility. And it's really our main way of communicating new knowledge that will change the practice of medicine. It also helps us train mentees and promotes them, and also promotes collaborators. And finally, it's fun, at least sometimes. And here's a great quote that I found in an article about publishing papers by Hashim El-Sarrag in Gastro in 2012. Which says, I would urge you to write not because it's a good thing, not because it's nice to see your name in print, but rather because you will get to know the field only if you contribute to it. And I really think that is incredibly true. So how do you get started? And we all have to start somewhere. And really a high impact publication starts with good science and teamwork. Picking the right topic to pursue is key. Making sure your knowledge of the literature in this area is deep and engaging with mentors and collaborators throughout the whole process, including right at the beginning in the planning phases. The best research and manuscripts really do follow the scientific method, including identifying an important question, generating an addressable and relevant hypothesis, designing and analyzing the study data, and then drawing reasonable conclusions. And many of the best manuscripts follow this pattern in general as well. And once the project starts, how do you know when to publish and what to include in each individual publication? One project can lead to many publications, or can several projects coherently lead to a single manuscript, which leads to an interesting concept known as the minimum publishing unit, meaning working to identify what is the best amount of information and the right amount of complexity to include in a particular paper. Knowing that too much is confusing to the reader and might limit the number of publications from a particular project, but too little in a specific project might not be as meaningful as a standalone manuscript, and will not lead to a high-impact publication in a high-impact journal. Another important thing to consider up front is authorship. Deciding on the authors and their order, at least preliminarily, as early in the process as possible is really very important, so that the roles and expectations are clear for each individual. And really only authors that have made significant and substantive contributions to the project should be included in the author list. The International Committee of Medical Journal Editors recommends that authorship be based on the following 4 criteria: substantial contribution to the concept or design of the work, or the acquisition, analysis, or interpretation of data for the work, and drafting the work or revising it critically for important intellectual content, and final approval of the version to be published, and agreement to be accountable for all aspects of the work and ensuring that the questions related to the accuracy or integrity of any part of the work are appropriately investigated and resolved. So what about the writing of the manuscript itself? Here are some general thoughts and tips about each section of the manuscript. And I'm starting with the abstract, as it's the first and really sometimes the only part of the paper that an individual reader will see. So this is really an important section rather than an afterthought. Make sure that when you're writing it, you're aware of the specific journal formatting requirements. I personally write the abstract last, after the rest of the manuscript, including its results and conclusions, are finalized, and certainly I would go back and at least revise it as the last step in manuscript preparation if you don't have that habit. And make sure that the most important results are clearly stated and that the conclusion at the end of the abstract really does address the question that you had endeavored to answer, but without overstating the interpretation of your findings. The introduction is also very important, and I would say that working with mentees, this is often the least understood section of the manuscript in terms of the fact that it requires the most rewriting. The introduction should be succinct, maybe up to 2 double-spaced pages maximum, and should not be an exhaustive review of the literature. It can be thought about as a section that draws a map of the research area and situates the current paper within this map. It can be viewed in three parts, with the first paragraph discussing the magnitude of the problem, the second paragraph highlighting the knowledge gaps that exist and their implications, and the final paragraph that states the hypothesis and the plan for the current study, to set up the reader for the methods, which are really the meat of the paper. The methods is also a section that should be really thoroughly vetted, and it is probably the section that is most scrutinized both by reviewers and also readers of the paper. There should be enough information here that the study could really largely be duplicated by any additional reader, and enough information that the reader will know how to apply the results to their patients or practice. Subheadings can be really helpful in the methods as well as the results sections. And for high-impact journals, depending on the study design, many will require that you adhere to specific guidelines for how certain types of studies are reported, such as having a consort statement for trials and meta-analyses. The results section is also read in detail by reviewers and readers, and it is important that this section present a logical progression of findings that leads the reader through the analysis in a logical way, and not really necessarily in the order in which the studies or procedures were performed. I do think subheadings are still really helpful here, and you should be careful to avoid adding additional analyses that really veer far away from the topic at hand. I also think it's really important to consider the tables and figures. Sometimes I even start with those before writing anything at all when I'm starting a manuscript. I think especially in this day of digital sharing, these should be standalone in the sense that they convey the main results and message of the paper in a self-contained way, including titles and footnotes and annotations if needed. And just like the abstract, there are some readers that will only ever look at the tables and figures to interpret the paper, so this also really can't be an afterthought. And finally, the discussion or conclusions, which in some ways can be thought of as a three-part section that is almost the opposite structure as the introduction, starting with the study's specific findings, followed by the contextualization within the greater body of literature, and then discussion of broader implications and speculation. It's important to remember not to oversell your data, to acknowledge limitations, but not to be afraid to highlight its strengths, and to always be honest in the reports of the data, in the citing the works of other authors that have contributed to this field, and also in drawing fair conclusions. I also just can't stress enough how much writing style really contributes to the readability of the paper and whether reviewers and readers are going to be receptive to the data that are being presented. Writing a manuscript is really similar to storytelling. It takes practice and it definitely gets better with time. Clarity and style may make the difference between getting into a high-impact journal and not having a high-impact publication at all, even with the same exact study design and data. So seek resources if needed to help with the clarity and style of the manuscript. And when in doubt, ask several people, including those not involved in the project, to read and interpret or comment upon the manuscript before submission. And once the science is done and the manuscript is a masterpiece and completed, don't forget about all the other things that go into a manuscript submission. Read the author instructions for each different journal once, if not twice. Some journals may allow you to submit without reformatting each time you go to a different journal, but many will not. And don't forget about or underestimate the importance of the cover letter, which is your opportunity to communicate to the editors and the reviewers why that journal should be a home for your work and what is really unique about this new manuscript. Now there's lots of new considerations as well. I think importantly thinking about in advance whether you'd like your paper to be open access. And finally, how do you pick your target journal? And what is a high impact journal anyway? What does the phrase high impact even mean? Often what it means in the community is in reference to the impact factor itself, but there's certainly more to impact than the impact factor alone. Important considerations include things like who really is the best audience for this information? What will the reviewers and readers think? Will they understand the field and why we've endeavored to answer this question? Who do I really want this message to get to in terms of changing clinical practice or basic science? Think about how quickly you'd like this information to be published. And I think it's never been more important to think about that than in this age of COVID-related research, where sometimes you don't have time to shoot high with your work and then get rejected from several journals because by the time it's published, it will really be irrelevant. But that said, All good work will find a home, so it's important to keep trying. It is important to know what the impact factor is, though, as this really is a very widely used metric. The impact factor is a calculation of a delayed metric. It's released every June and reflects the citations from the previous calendar year to articles published in the 2 prior years. So as an example, the last impact factor calculation was released in June of 2021, and it included citations in 2020 for articles published in 2018 and 2019. And this is divided by the number of total source articles in those 2 years, 2018 and 2019. The source articles that count in this denominator are original articles, guidelines, proceedings, reviews, case reports, and some other article types, but generally doesn't include editorials, letters, and abstracts, which can be counted in the numerator but not in the denominator. Beginning this year, there was a new change, which is that a final version of an article published online, it is counted as published. Prior to that, it was counted as published when it actually was published in print in an issue. And this impact factor is sometimes used to rank journals in different fields. And I'm showing you this list not because the impact factor is the most important part of it, but also to generate a nice list of journals that you should think about before submission for work in the fields of gastroenterology and hepatology. So this is the 2020 impact factor rank list for all GI and hepatology journals. And you can see here that hepatology is among one of the highest ranked journals. Its impact factor increased to 17.425 from 14.679 in the last year, and it's ranked 6th out of the 92 gastroenterology and hepatology journals. And here you can see a similar list for transplant journals. One of the nice things about our field is that we have many different types of journals to go to. And here you can see that liver transplantation's impact factor increased last year to 5.799 from 4.570 and is now ranked 26th out of the 92 GI and hepatology journals, but 4th out of all the 25 journals in transplantation. There are other metrics out there, though, and I think this is really important and is becoming an increasingly important part of sort of tracking publications and the impact of journals and articles. And perhaps one of the most frequently discussed is the alt metric, which is now being reported even on publishers' websites along with individual papers. This metric is a real-time metric. It's not delayed by a year or two and includes many different sources of citations, not just citations in the formal medical literature. And this includes citations in public policy documents, websites, Twitter, and lots of other sources. And when you look at metrics for an individual paper, and I've shown you just an example of a paper here, it includes all the different types of citations and the locations around the world where the things were cited, a lot of granular information, which I think can be really interesting as an author to see who your work is reaching and how. So to take some of the AASLD's high impact journals as examples, and in particular liver transplantation, I'm just going to walk through a little bit about the sort of editorial process with some pearls in terms of submission to help you get things published. So when selecting a target journal, there's a lot of helpful information on the journal's website, including not only the author guidelines, but also what really is this journal interested in? What is the vision of the journal? What is the mission? And does your work really fit with this? And more specifically, take a look at the table of contents, including the titles of the different sections that are available, as well as actually the individual papers that were published. You could even focus on those that had editorials associated with them, which sort of might signal the editors had specific interest in that type of work. Then think about the categories of manuscripts that the journal considers and whether your work fits into any of these particular categories. For example, is a short format better for a study that really has a succinct message and could be boiled down to a shorter number of words and references and tables, or is a full manuscript the better format for your individual study? And when you're looking at the author guidelines for each journal, all the different types of formats will have different guidelines in terms of word limit, abstract limit, the numbers of tables, figures, and references allowed. Once the manuscript is submitted, here's an example of what happens on the editorial side at liver transplantation in particular, which is that the editor-in-chief makes an initial decision about whether to early reject a paper that doesn't seem to fit with the journal's mission without additional review. However, if they decide to proceed, then that paper is then sent on to the deputy editor, who has that same opportunity to early reject a paper. If they decide to proceed, they then assign it to an associate editor, who then assigns a number of different reviewers. They continue to assign reviewers until at least 2 agree to submit reviews. And when the reviews are submitted back to the associate editor, they make an initial recommendation. That recommendation goes back to the deputy editor. The deputy editor makes a recommendation that goes back to the editor-in-chief, and the editor-in-chief then finalizes the recommendation. And for liver transplantation, the different choices include early reject, reject with reviews, reject with opportunity to resubmit, accept with revisions, or accept outright, which I would say is extremely rare on the initial round of reviews. And when discrepant opinions occur, which is not infrequent, there's lots of conversations that occur between the different parts of the editorial team to resolve these specific issues. And overall, this process we hope will take about 20 to 30 days. We, like many journals, have tried really hard to keep this review time as short as possible and to be sensitive to the author's needs to have a decision so that they can move on, and to continue to publish timely content. And again, I think this has never been more important than it has been in this last couple of years of COVID-19 publications. And overall, we have an acceptance rate of about 15%, with about 20% of our manuscripts being rejected without review, and another 80% that are sent out for review, but then only a minority of those go on to be published. So what are the editors looking for in general? And here are some insights from Dr. Nathanson when he was the editor of Hepatology and published this opinion piece in 2015. And the issues that are really the most important include overall novelty of the work, its contribution to our pathophysiologic understanding and or to our clinical practice, whether the work will be generalizable, and whether there's certainty about the findings that are reported. And for basic research in particular, again, are the findings novel? Do they provide real mechanistic explanation, or are they really just observations? And are there in vivo data or findings of human relevance? Common pitfalls that are raised in the review and editorial process include insufficient novelty, insufficient evidence to support the conclusions, methodologic issues, and I think another really common thing is really limited interest or a lack of priority for the chosen journal. In summary, remember that writing is fun and a great way to learn, disseminate knowledge, and advance your career. It's a process that starts with good science and teamwork. It's important to define what will make this work high impact for yourself, remembering to focus on your target audience. And finally, remember that writing, like research, is an acquired skill that takes practice, and that all well-conducted studies have value and will find a home eventually. So learn from your critiques, have thick skin, and don't give up. Thank you for your attention, and I look forward to your questions.